So the topic is artificial intelligence in quality and safety in imaging. These are my disclosures. I will deal about the applications of artificial intelligence with regards to quality and safety in imaging. This can be divided into several subheaders. We'll see how artificial intelligence can be used before we acquire images, and how artificial intelligence helps us during image acquisitions, and how it can be used to process the images and manage the images, then how it can help during image interpretation, and finally, how AI can help us in generating succinct radiology reports. So the first domain would be how we can use AI before we even start acquiring images. So the first application would be to choosing the indication for a clinical condition, and also what is the appropriate imaging modality. So this would fall under the domain of clinical decision support. Then how we can safely choose a imaging modality, and how we can schedule the most appropriate imaging study. So before we choose imaging modalities, we have to think about what is the most appropriate imaging study that can be performed for a given indication. Say, for example, if you want to image somebody with a headache, you can go into any of these artificial intelligence programs and say, hey, what is the optimal study for somebody with headache? So then there are a number of indications, but then if you ask a question such that to ChatGPT, it will blurt out all the pertinent information. It will tell you that it's the most appropriate study for detecting brain hemorrhage, for detecting blood clots. It's also a good study for imaging brain infections, and so on and so forth. But it also helps you by directing you to appropriate websites, like, say, for example, American College of Radiology appropriateness criteria. So if you go through the ChatGPT into ACR guidelines, then you have a more detailed indications when a head CT is appropriate in somebody presenting with headache. Say, for example, somebody who has a new onset headache in an elderly individual, or somebody who has severe headache that is rapidly worsening, or a headache that is associated with some neurological symptoms, so on and so forth. So it helps you to choose the appropriate imaging modality. It is important to understand that choosing a modality is not as easy as you think it would be. This is a study which was done in which it was found that the imaging study that was chosen was discordant for the clinical indication, or the study was not a complete examination for the pertinent clinical indication. So if you look at this number, there's a lot of room for improvement. And by choosing artificial intelligence tool, probably we can bridge the gap. So this is a retrospective study where a artificial intelligence leveraging free text imaging order entry was used to facilitate federally required clinical decision support. Now it has become a more common practice in US to use a clinical decision support tool to appropriately use imaging tests, and also to use them safely. So by doing so, the authors have found that there is improved accuracy in choosing the appropriate imaging modality. The accuracy has improved to 91.7% compared to the modality that was chosen without using artificial intelligence tool or algorithms. So It is also important to look at the error rates or quality issues or safety reports that resulted from various imaging procedures. By using artificial intelligence tools, it allows you to do a sort of a data search and figure out the safety reports and the quality issues that arise from various imaging tests. So, this type of data mining is not always accurate. There can be false positives associated with it and also false negatives, which can range between 13 to 29%. But it's a good tool to quickly look at your instances of safety reports and errors that happen during various imaging tests. So during image acquisition, there are several ways we can use artificial intelligence tool. The first and foremost is choosing the appropriate imaging protocol. Then to help in optimally positioning the patient by using various tools, for example, a tool for patient centering. We can also optimize contrast delivery and image acquisition by bolus tracking and also timing the contrast injection. And also in some instances, like for example, MRI imaging, where there are multiple sequences that are available, we can optimize the MR sequences for better lesion characterization. So first is choosing the protocol for imaging study. Say, for example, we know that there are multiple phases of CT imaging or image acquisition for abdominal CT. We can start with non-contrast, we can do portal venous phase, we can do delayed phase. Sometimes we can also add arterial phase. So we can ask any of these artificial intelligence tools or algorithms to suggest to us what is the most appropriate imaging protocol. As you can see here, for vast majority of the abdominal indication, a single phase study is sufficient to answer all the questions. But in some instances, say for example, when you're looking for characterization of lesions such as hemangioma, we may need to do a delayed phase CT scan. Or if you're looking for arterially enhancing lesions such as pancreatic neuroendocrine tumors or melanoma metastasis, we may have to add arterial phase. But these instances are not that frequent. So for vast majority of the cases, just doing a single phase study is sufficient. And by doing so, you actually reduce the cost of the imaging by saving the radiation output and also increasing the prolonging the life of the CT tube. But you also importantly reduce the radiation dose to the patient. Similarly, if you, this is a question which Manu asked the ChatGPT, what is the most optimal phase or protocol for imaging abdomen? And it says the same thing. It says single phase is sufficient for most of these indications. But in select cases, maybe you have to tweak the protocol to characterize the lesions. So same thing for the chest CT. I'm a thoracic radiologist, so I'm partial towards chest imaging. For chest imaging, for most situations, a single phase chest imaging is sufficient. In select cases, say for example, characterization of a lung nodule, sometimes we have to acquire delayed images, or we may have to acquire images during arterial phase and venous phase. So these are some select situations which are not routinely performed. Therefore, by understanding what is the optimal protocol or most commonly used protocol, we can reduce the radiation dose delivered to the patients. The take-home point is by using AI-based tools and choosing the optimal protocol, we can choose the appropriate test. Therefore, we can reduce the radiation dose, and also there is a benefit for potential cost savings in these patients. So this is another application of the AI. This is available in advanced or newer CT scanners. This is not available in our hospital, but it allows you to properly center the patient by also adjust the table height. Therefore, the images are for much higher quality, and also it reduces the radiation dose to the patients, and it also reduces some sort of artifacts such as truncation artifacts by making sure that the patient's body is not touching the CT gantry. It can also enable us to choose the scan range, therefore reducing the scan length and therefore reducing the radiation dose. It also can help us optimize the contrast density in the vasculature and appropriately trigger the scanning. So in summary, AI can help in better positioning of the patients, improves the quality of the examination, and it also can help us choose the correct protocol and also modify sequences for MRI to optimize lesion characterization. There are a number of papers which have looked into the advantages of AI-assisted centering. These are three such studies. And these studies have shown that by using automatic centric, the offset of the patient can be minimized, and it makes the job of technologist easier. It also will reduce the artifacts. And there is also actually a saving of the radiation dose. The other common problem we have in imaging is when we do a number of studies, particularly imaging in critically ill patients, what we do is image them on a regular basis. They have a lot of supporting lines and tubes. Therefore, we end up getting some suboptimal imaging studies. This is particularly true for portable radiographs. So this results in some of the studies being rejected, being not good enough for interpretation. So this requires repeat radiographs. But if this is not recognized at the time of image acquisition, this might necessitate repeat imaging after a few hours. This may cause more inconvenience to the patients and also to the radiology staff. So if you have a system that allows us to identify the quality of radiographs, that will be incredibly helpful in identifying the suboptimal radiographs and reduce the reject rates of radiographs. So to summarize again, before we acquire the images in CT scan, we have seen that it helps us to position the patients by optimizing patient centering. And it also will help us to optimize the tilt and rotation of the patients. It will also optimize the distance from the source to the detectors. All this improve the image quality. After the images are acquired, it also tells you if there are any technical factors that might compromise the interpretation, such as, say, exclusion of a important anatomical region, or problem with the technical parameters or artifacts. So, for example, in a radiograph, we may exclude the lung apices, we may exclude the CP angles, or the patient's face may obscure part of the anatomy. The radiograph can be overexposed or underexposed, or there can be artifacts related to external objects, such as EKG leads or some other object lying on the patient, which may cause problems with the interpretation. So there are a number of issues with portable radiographs. So we have looked at a software which trained the model about the various type of reasons which can affect the quality of radiographs. After training the model, we wanted to check if this software would be able to identify suboptimal radiographs and would issue a prompt to the technologist so that the technologist would immediately rectify by repeating the chest X-ray. So this study, which was done as a research project by one of our fellows, was presented recently, and it was received very well. Similarly, AI-enabled fluoroscopy for automatic collimation can reduce the radiation dose. The savings in radiation dose can be significant compared to the standard fluoroscopy done without AI assistance. After the images are acquired in the post-imaging phase, we can use these AI tools to estimate the radiation dose to different organs. We can use AI-based image reconstruction algorithms. We can also use post-imaging reformats using AI-assisted or AI-based algorithms. Then finally, we can also help in faster image interpretation by flagging these studies, which can potentially have important or significant findings. So the first aspect would be AI image reconstruction, which is applicable both for CT and for MR. The most important advantage of this AI-based image reconstruction is reduced radiation dose without significantly compromising image quality. The noise is not too much, and it also has the potential to reduce various artifacts. So this is in comparison to iterative reconstruction techniques. As you know, there are three basic type of image reconstructions techniques. The one which you are familiar with is filtered back projection. That was how CT has started. Since then, we have moved on to iterative reconstruction techniques, which showed significant improvement in terms of better image quality with reduced noise, fewer artifacts. These could be achieved with lower radiation dose. A step forward from iterative reconstruction is deep learning algorithms, which can further reduce the noise, improve the image quality, and further reduce the radiation dose. Or even if they do not reduce the radiation dose, even when compared to the iterative reconstruction techniques, the image looks much better with lower noise and fewer artifacts. There are a number of deep learning iterative reconstruction techniques or reconstruction techniques. Some of these are vendor specific. For example, true fidelity is a DLR technique that is associated with GE. And similarly, there are techniques which are proprietary to Canon. But there are also some algorithms such as Clarity, which are vendor neutral, and these are applied to images acquired on any CT scanner, irrespective of the vendor type. So these are a number of papers, and all have shown uniformly that the DLR techniques reduce the noise, improve the image quality, and they also improve the conspicuity of the lesion. So these are some of the examples in different body parts. On the top is the CT scan, which is obtained with iterative reconstruction, and the bottom is the DLR technique. As you can see that the bottom images look much smoother with lower noise, and there is better gray-white matter differentiation compared to the top row. Similarly, in the chest, at the level of shoulders, usually we see a lot of artifacts from in the shoulder region, but these noise and artifacts are significantly less with DLR technique, as you can see in the bottom image. Similarly, these are the images in the abdomen. The coronal views show that with these filtered back projection, there is significant noise in the top left image, whereas by using various DLR techniques, we can smoothen the image, and on the DLR with high strength, the images look much smoother. The conspicuity of the lesions, if you focus on the cyst in the left kidney, they appear much more conspicuous. The artifacts are less, the noise is less. But DLR techniques can have some pitfalls also. The one thing we noticed was when you're looking for subtle findings, such as cyst in the lung, the borders of the cyst may not be as sharp, but overall, it does not compromise image interpretation. But if you compare side by side, the cyst in the DLR image appears slightly less conspicuous compared to the IRT image or iterative reconstruction technique. We can also apply denoising algorithms after images are acquired. So here we have got an example of pelvic and soft tissue windows and the lung and chest in the lung windows and the top row. And on the bottom row, after applying this denoising algorithm, you can see that images appear smoother. There is less noise. And in the lung, the dependent atelectasis or ground glass opacity in the lungs appears less conspicuous after applying denoising algorithms. But deep learning algorithms do have some limitations. The first and foremost is it is not widely available, and this is available in the newer scanners. So buying this software can be costly, and there is a potential for dose reduction, but I would say that at this time, the images appear less noisy and they have fewer artifacts compared to the iterative reconstruction. Therefore, one should not aim for dose reduction, but we should aim for better quality of the images for the same radiation. But it's quite possible in future that there's also potential for dose reduction for CT images. I do not have much experience with MR images, but this is a example borrowed from literature where by applying AI-based reconstruction, the artifacts in the images could be reduced. As you see, this linear artifacts in the overrunning the liver, they were removed after applying this artifact reduction tool using deep learning reconstruction. This technique or technology can also be applied for PET images. On the top row and the bottom row, you see two sets of images where you have low dose PET imaging. Then at the very end, you see the deep learning reconstruction techniques, which makes images better. The photon distribution is more uniform and the artifacts are less. So we are also working on the newer AI-based algorithms. The one which we are working on is a algorithm which does two things. It improves the contrast in the blood vessels, and it also reduces the denoising. So this is an example. If you see here, the kidney appears brighter, the aorta appears more brighter, and the noise is also less. Therefore, we can better appreciate the heterogeneity of the liver parenchyma. So this is another example. If you notice the contrast density in the hepatic veins on the left image, it appears brighter, the noise is less, and also the tiny hypodensity in the left hepatic lobe is more conspicuous in the images reconstructed with AI-based contrast improvement and denoising called Clarity. So we can also rescue suboptimal images. A study which is not very good for detection of pulmonary emboli can be made more diagnostically acceptable by displaying the filling defects in the pulmonary arteries. This is true for soft tissue windows and also for lung windows. So some of the pulmonary emboli which were missed on routine CT scans were detected after AI tools, which allowed better delineation of these filling defects within the pulmonary arteries. So after images are acquired, how can artificial intelligence tool help us? The first thing would be they can help us in triaging the images that were acquired. Then it may prioritize the list. It may make your work list more efficient. And it also helps you to message or communicate with the referring physicians in a timely fashion. So there are a number of findings which these AI algorithms are capable of detecting. For example, in the chest X-ray domain, we can detect pneumothorax, pneumonia, pleural effusions. In the head CT, we can detect intracranial hemorrhage. It might help us detect cervical spine fractures. Then there are tools which are very good at detecting pulmonary embolism. It can also detect suspicious breast lesions. So we know that there is a shortage of radiologists worldwide, and there is a significant delay between image acquisition and image interpretation. For example, in a study done in United Kingdom, they said there are a wait of more than 30 days for interpretation of chest X-rays. They did a study, they used AI triage to detect important findings or critical findings on these chest X-rays. And by doing so or flagging these studies, they could reduce the interpretation time significantly. The interpretation time dropped down to from 11 days to 3 days. So we can also use those type of tools in our practice. So we are still in the early phase of implementing these different algorithms in our work practice, but we have done in a research basis. And we do see a lot of potential of AI in triaging these important findings in various imaging techniques and body parts. So this is an example of automated triaging of adult chest X-ray using a deep artificial neural network. And Manu has done a lot of work in this domain. We have evaluated various softwares, and we published a lot of many papers. And we also found that these tools can be helpful in triaging these patients. So there are a number of areas in different body parts where AI tools have been used to identify in terms of, say, for example, brain, in identifying anatomy or detecting brain hemorrhage or intracranial vasculature, and also for segmenting brain tumors such as glioma. In the chest X-ray and chest CT, these tools can be used to detect pneumothorax, quantify or semi-quantify quantification of emphysema, bronchial wall thickening, detection and characterization of pulmonary nodule, pulmonary embolism. So in every body part, there are emerging applications of AI-based lesion detection. I want to show you some examples how we can potentially use. For example, in the chest X-ray, we can use various AI-based tools to increase the conspicuity of findings. By using edge enhancement, pneumothorax can become more conspicuous. By subtracting the bones, we can make the lung lesions more conspicuous. So these are some of the applications, and in some of the studies with which I have some personal experience, we found that these techniques can help us. In the CT, we can also use AI-based algorithms to reduce or subtract the pulmonary vasculature, and therefore making the lung nodules more conspicuous. So for example, this ground glass nodule in the left upper lobe is more easy to detect when you subtract the surrounding pulmonary vasculature. So therefore, it also makes it more easier to characterize this nodule, whether it is a pure ground glass or it is a part solid nodule. And these tools are very advanced. They also give you the volume of the nodules, and if you can compare them over a sequential studies, it will also tell you the incremental growth, a change in the volume over a period of time. More recently, the interest has shifted to other pathologies of the lung beyond nodule detection and characterization. AI tools have been used more frequently now to quantify COPD, to understand the significance of the airway thickening and the extent of bronchial valve thickening. So these are some of the things which will have a lot of applications in future in management of patients with COPD and asthma. The other areas where AI is useful, and especially in terms of reducing the time of interpretation, is straightening or unfolding of the ribs. It does two things. One, it displays the ribs as a straight line, so it unfolds them. And two, it also numbers the ribs, so it makes your interpretation easy, and it know where the pathology is located and which rib. So this is a tool we have been using in our practice, and I find it very useful for both identifying the lesions and also for accurate anatomical location in terms of the rib number. AI-assisted spine labeling has also been in practice for some time. It can straighten the spine, and it also allows you to label the vertebrae. You have to choose one vertebra as the landmark, then it can label the other vertebrae automatically. Again, it helps you the same way. It helps you to pick up the lesions, and it also reduces the error of counting the vertebrae, so you're more accurate, and it also saves you time. But now we have gone to the domain of more comprehensive AI. It is not just nodule detection or just a tool for detection of pulmonary embolism. By using this comprehensive AI techniques, it's a one shop for everything. So you can do nodule characterization, nodule detection, you can quantify emphysema, you can assess bronchial walls, you can make measurements of iota, you can estimate the coronary artery calcium, and if you want, you can also do the same things such as unfolding, rib counting, also counting of the vertebrae, and this is something which can be done. So now because of instead of having multiple different algorithms, you can have one algorithm which is capable of performing all these tasks. Therefore, it saves time. So finally, we move on to the reporting of the images. So most of these AI-assisted programs are capable of exporting their findings into the radiology reports. If you have a software which can communicate with the AI programs, most of the voice recognition system which are currently available have some capability to interact with the AI algorithms, so that those things can be directly exported into the your reports which are being dictated. So you do not have to copy anything, so you can just export them into your radiology reports. Similarly, we can also use AI tools to generate impression based on what you said in the findings section of the reports. This is still in a development phase, but the initial results are very promising. So it has the using language processing algorithms, natural language processing algorithms, it can understand what is said in the report in the findings section, and it can generate a succinct impression, so thereby saving time. And also it minimizes the risk of not mentioning, which is important in the impression. So this is a screenshot of how such a system would work. You can look at the findings, then you can look at the impression generated by the radiologist, then you can also compare to the impression generated by the AI algorithm. And in many instances, there is a good correlation between the impression generated by the radiologist and the impression generated by the AI software. But still, it's a work in progress. In a simulated environment, these things work very well. We have to see how effective these are when widely implemented in clinical practice with a radiologist of different styles of reading the scans. So this is a study done by Monu, and they found that in a multi-dented data set, it was performing very well. And also in single center reports, it also performed reasonably well. But when you apply in the routine clinical practice, it falls short of the expectations. But as I said, it's still a work in progress, and hopefully in future, the results will be better. So after we report the scans from a quality perspective, you also should have a peer review process. We can use AI as a second reader or a self-review to make sure that you have not missed anything which is important. Or you can use AI tool as a peer review, and therefore we can also save some time by not doing a peer review by another radiologist. So this comes into the domain of predictive AI. So this is a study published by one of my colleagues in cardiac radiology. They used deep learning algorithms to assess the outcome. In this particular paper, they looked at the chest X-ray, particularly they focused on the coronary artery calcium, and to see how it correlates with mortality and the survival of these patients. So then we have to focus on the validation of various AI algorithms and how generalizable are these algorithms. So there are a lot of work is being done. There are guidelines from FDA, and different radiological societies have their own guidelines. So people are using various techniques or trying to achieve some standardization to see how this AI algorithms can be vetted, so that the safety aspect of this algorithms is also good. So that brings us to the important thing. We know that we are using AI to improve quality and safety, but who is going to monitor the quality and safety of various algorithms? So this is something we should also be working on simultaneously, so that both are complementary to one another. So to summarize, we have seen that AI can be used to improve quality and safety in various aspects of imaging, starting from protocoling, scheduling the studies, to image acquisition.
Morning, मैं 2 minute बोलूँगा. Phone में.
And so many are FDA approved, and some of them are available in our hospital also. And I want to thank Manodeep Kalra, my colleague. Our offices are across the corridor. So he's an incredible resource, and he has done phenomenal work, original work. And I'm very grateful to for his help and guidance. I'm happy to take any questions. Thank you.